So it's really important to understand or know if the infection that is the result of your patient's illness is stemming from a gram-positive or a gram-negative bacteria. And the reason this is evident is because basically what we're looking at when you compare the difference between gram-negative or gram-positive, we're looking at the kind of the outer membrane, which is demonstrated here. And so there are several proteins in that membrane that are pharmacologic, excuse me, targets that basically the antibiotic binds to. And so depending on the chemistry of either the gram-positive or the gram-negative cell wall, you can kind of justify selecting a specific antibiotic because of what's there. And so when we look at the constituents of the gram-positive cell wall, for example, we see lots of peptidoglycan. Okay, of course there is peptidoglycan in the gram-negative wall, but it's comparatively lower in abundance. Okay, and so this is important from more of like a chemistry perspective, is that, you know, in terms of whether or not your target is there, determines how readily drug will bind to. And so if the drug is specific to peptidoglycan, for example, the incidence of that drug, or the likelihood of that drug binding to peptidoglycan here, is much higher compared to the likelihood of that drug binding to peptidoglycan here. Okay, so that's just as an example. And there's other examples to that as well. The permeability of these two walls is different, and I know Dr. Richards will spend more detail talking about what makes up these cell walls, but you know, just from a pharmacologic standpoint, you have to determine if your molecular marker is there, whether or not these drugs will actually work in these specific bacterial infections. And basically this diagram summarizes the same thing. Here you see really nicely the gram-positive bacteria have a much thicker peptidoglycan wall that's obviously exposed. Here's the gram-negative bacteria, obviously a thinner peptidoglycan wall, but there's a cell wall. So this forms another barrier. And so in terms of the chemistry of these antibiotics, if it can't get through the cell wall, it will never have the ability to bind to the peptidoglycan layer. Okay, so we'll talk about that in more detail as we go further through this module. Other things to keep in mind is whether or not a given antibiotic is bacteriostatic versus bactericidal. And so bacteriostatic drugs basically arrest the growth and replication of the offending bacteria. Okay, and so one key concept here is that the number of the bacteria per volume stays the same. So these drugs often work together with the immune system, and what they do is they basically weaken the drug. The drug weakens the bacteria in order so that the body can kind of take over and the appropriate immune response for eradication of the bacteria can ensue. Now, there are instances where we need to be a little bit more aggressive in terms of therapy, and we need to go right to a bactericidal agent. And so bactericidal drugs actively kill microorganisms, they actively kill bacteria. And so here, if you're looking at what the bacteria are doing in vivo, they're actively dying, and the number of bacteria per unit volume ends up going down. And so the beta-lactams, vancomycin, aminoglycosides, quinolones, and so forth, these agents tend to be bactericidal. Okay, and so this is based on phenotypic characteristics. This is not necessarily based on chemistry. And so, of course, there are exceptions to the rule. The precise distinction between them is relative to the dose often that is given. And so typically at normal doses, a drug can be bacteriostatic, but in extreme situations, if there's a specific infection in a compartment, think maybe like in the meninges, of course, you can see the use of much higher doses. And of course, at those higher doses, that same antibiotic, which used to be bacteriostatic, can now be bactericidal. Okay, and so, and of course, different bacteria would have different responses to the same antibiotic. So certain antibiotics may be bacteriostatic for one group of bacteria, and that same antibiotic could be bactericidal for another group of bacteria. And this is kind of graphically what we're looking at here. And so the green line is a typical bacteriostatic drug. And so at this point right here where this arrow is where you can kind of see the antibiotic being administered. And if the amount of bacteria basically remains the same while the patient is on the antibiotic, we can say that the given drug is a bacteriostatic drug. And we know this because when we take it away, the population of the bacteria starts to climb up again. Okay, this would be in contrast to if you were to add an antibiotic at this point right here, and the number of bacteria cells per unit volume started to plummet. That's a good indication that what you're looking at was a bactericidal agent. And so there are some clinically useful assessments that can predict whether or not a given antibiotic will be successful in a patient. One of those is the MIC, or the minimum inhibitory concentration, or the minimal bactericidal concentration. And so the MIC is the lowest concentration of an antibiotic that inhibits bacterial growth within 16 to 20 hours of incubation. And so there will still be the same number of so there will still be small numbers of bacteria, and basically the MIC is a measure of the potency of the drug. This would be in contrast to the minimum bactericidal concentration of the MBC, and this is the lowest concentration of an antibiotic that's required to kill 99.9% of the bacteria after 16 to 20 hours of incubation. And you know the MBC was successful because the outcome should be that there would be practically no bacteria observed. So this next picture is a nice diagram comparing and contrasting the MIC versus the MBC. And so here's serial dilutions taken from a patient and then spiked with a known concentration of antibiotic. Okay, and so you can see at 1 microgram per ml and 2 micrograms per ml and up to 4 micrograms per ml, we can still see some bacteria. You can see an attenuation or reduction of bacteria, judging by how dark these test tubes are. By 8 micrograms per ml, the solution is more or less clear, and you can only see bacteria when you subculture a couple drops of this solution onto agar. Okay. Likewise, at 16 micrograms per ml, we see no bacteria being subcultured. Okay, and so 8 and 16 are kind of our magic numbers. 8 represents the MIC. It's the minimum bacterial concentration that we can see. And then the MBC is the 16 microgram dose. And so here we see is the first instance where we see no bacteria at this dose. And so these two are kind of two very key phenotypic descriptions of the MIC and the MBC. And this is clinically relevant because we need to know what dose of the antibiotic the patient should be on to produce maximum effectiveness. And so if our goal is to eradicate every single living bacteria, and we want to have a bactericidal agent, we're going to shoot for the MBC. And if our goal is to just basically suppress the bacteria long enough so that the immune system can take over, and ideally the patient would be healthy and capable of doing this, the MIC would be more or less sufficient. Okay. Now there are certain diseases that require you to be more aggressive and you must administer the MBC dose. And there are other diseases that are not quite as serious, but they should still be treated, and they would require you to just basically give the MIC dose, and that should more often be sufficient for the long term. Let's end here and we'll talk about another clinically relevant way to assess the potency of a specific antibiotic.